Hello. So I'm Kelly Bork. So I am going to introduce Dr. Schnell. I'm one of the kind of planners of the event and also talking a little bit later on antibiotic stewardship and antibiotic inequities. But Dr. Schnell, she graduated with her bachelor's in science from the University or Psychology of Mid-American Nazarene. And then she went to KU for her doctorate and completed her doctorate of pharmacy. She also did her MPH at George Washington University, which is where I did mine also. I don't know if I told you that. And so Dr. Schnell previously served as the lead clinical pharmacist at Osawatomie State Hospital, and she's currently serves as the director of pharmacy at Cass Regional Medical. She is a clinical pharmacist also at the University of Kansas Health System. So she advocates for equitable health services in all areas of healthcare settings, innovatively addressing underserved patient populations and communities. She also is the immediate past president of the Kansas Pharmacy Association, the Diversity, Equity, Inclusion Task Force, also chair of the Pharmacy Leadership Society, and is the office-elect of the American Pharmacy Association. Also, Dr. Schnell resides in Lewisburg with her husband and 3 sons.
Thank you, Kelly. I, like Dan this morning, am a very laid-back presenter. So I'm going to tell you if I understand that a lot of people don't know a lot about pharmacy, and that is our fault, like the pharmacy's fault. We're very insular and have been insular in the past. And so part of our conversation today about these challenges and barriers that are existing is partially to educate you on what's going to roll your way in the community space, because you may not even know that it exists because it is very insular to our profession. So hands in the room, a lot of my work is done in rural health. I grew up in rural America. For those of you that are in the room, as far as where you're practicing or serving, however you decide to determine that, how many of you are in a rural environment? Okay, perfect. We're going to talk a lot about rural Kansas today and what's going on in those spaces. That is different than, is anybody in a suburban environment where they practice? Okay, perfect. And then an urban environment. Okay, we got some urban environments. Now, the causal factors are pretty much the same when we talk about pharmacy deserts in general. So we're going to talk a little bit about that today, and I'm going to go through my objectives in a moment, but I do want to give a disclaimer. So I am not a primarily trained pharmacist, meaning like my primary training was in business. So I look at this a little bit different than a traditional pharmacist does because I worked in corporate business and can kind of see the business side of what has taken place. So pharmacy is a business, just like providing healthcare is a business. If nobody's informed you on that, we live in America, it is a business. You know, contrary to some of my brand new practitioners that come out and work with me, I'm like, that's cute that you believe that there is not money involved in this, but there most certainly is. And this is an example of that, of what we're going to talk about today, is when business gets involved with the provisions of care and what happens as a result of that. And this is really a case study for that, what we're going to talk about inside of pharmacy. So if you know nothing about pharmacy, just know that you're going to get bathed in the water today. We are going to have the conversation. So our goal today is we are going to describe the role of the pharmacy benefits manager, pre-claimer. The pharmacy benefits manager, even though I'm going to talk about them a lot and educate you on that so that you understand why we're where we're at, they have not, in fact, actually done anything wrong. Just to be clear, they have not done anything illegal. That is also a clear point. However, their business interests and the business interests of care are 2 different things, and there are downward spiral effects as a result of that. That's my disclaimer. If I was a wonderful businesswoman in charge of pharmacy benefit manager, they wrote the book on how to make money, okay? Defining the term of a pharmacy desert. Understanding the differences between medication access and adherence, which is something, when we talk about that, when I was in public health school, George Washington University doesn't have a pharmacy school associated with it, so I got to learn where nobody had like really any involvement with pharmacy, that we focus very much on access, but we don't talk a lot about the adherence aspects inside of our interventions when we're planning them, and that's the most important. I can get you the drug, I can get you it, but that doesn't mean you're going to use it and that it's going to actually impact things. So how is that married together? Identifying risk factors that have unique impacts on patients in rural Kansas communities. differentiating between the causal theories and contributing to the increase in pharmacy deserts locally, and then assessing solutions and addressing barriers to medication access. It's a lot. I'm going to talk quickly. If you have questions, like I said, if I use a term, I'm going to try and define things in front of it. If you're like, I am so lost in the weeds right now, Tessa, just raise your hand and I will be more than happy to provide a clarification. You should not feel bad about that at all. Okay, so we're going to talk a little bit about the background. Now, this photo that I have up here on the screen, it has to do with the vertical and horizontal integration of pharmaceutical care in the United States. And so I think it's important, especially when I talk to individuals about the work that I've been doing, is to understand you got to look backwards to go forwards. So you have to understand how we got here, because when we're just looking at the symptoms right now, and we're trying to solve symptoms, there may be some secrets in the past that you can look back at and be like, this is not a good pathway to solve this problem because it's actually the reason why we ended up here. Right now, I will tell you that pharmacy is in survival mode, so they're scraping at all these different things. So looking at a longitudinal plan that will actually solve this is key. History repeats itself, so we're going to talk a little bit about that. This is my most scripted portion of this, and I'm going to kind of give you a history and a rundown of the players that are on this board. So the first PBM was in the United States was founded actually by a pharmacist in the 1960s. So this was in response to increasing drug prices and in a cash paying market. Think of it as like kind of like Sam's Club, Costco. I buy into a membership, I get a decreased rate at my pharmacy on my prescriptions. Okay, so 1920s, so this is in the 1960s. 1928 is when penicillin was discovered, and then as soon as penicillin was discovered, like you guys are getting a history lesson, sorry. As soon as penicillin was discovered, then this whole entire robust development with industry and pharmacy industry took off, and we ended up with legend drugs, lots of legend drugs. When I refer to legend drugs, that's the difference between what we keep behind the pharmacy shelves and the over-the-counters that are on the front, okay? So as a result of that, a lot of prescription medications by trade names, you end up having to recoup R&D, so prices go up, right? So our research and development, we have to charge more for the drugs to be able to recoup the costs of actually developing them, okay? So we're trying to pass that on to the payers. The pharmacists realize this. They're going to do a cost-saving solution. They create the pharmacy benefit manager. It was originally created by pharmacists. All right, so as these advanced, in the 1970s, there was the creation, you guys may have heard this term, ERISA. Okay, so ERISA means the Employee Retirement Income Security Act. When ERISA plans started to exist, it paved the pathway for cost reduction strategies to be deployed in prescription drug plans, and pharmacy benefit managers could be hired to manage such plans on behalf of the employer. So we're now involved with employers, not just patients and pharmacies and being a part of a club to get discounts. This ERISA plan in the 1970s served as the current springboard for what we kind of see today with PBMs and the business model. Although there was this was the beginning of the vertical and horizontal integration that began in the 1970s. It is the emergence of the modern PBM era. And you're like, what is this? So what happened is in 1998, Rite Aid, which was a pharmacy, purchased what was called Pharmaceutical Card Systems, which was called PCS, which was considered the modern version of the very first. That's usually what they term when they say the first PBM. So with that PBM, this was the first time a national pharmacy chain kicked off a series of acquisitions, and a new model was born for PBMs. So we're no longer back with like trying to necessarily save money for our patients. It's about saving money for employment plans. It's about saving money for other entities, not necessarily patient focused. So just to be clear there. Then, so we're still on the timeline, so that was 1998. In 2005, United Healthcare purchased a company called Pacificare. They owned a PBM that would later be renamed to OptumRx, which you guys may be familiar with Optum. Shortly after this, so 2 years later, CVS acquired Caremark, followed by in 2012, Express Scripts purchased another large PBM called Medco Health Solutions. So all this vertical and horizontal coming together. What happens when you don't have competition? drives prices up, okay? We know that, basic economics, that's a business lesson for you. Basic economics, okay. So quickly these blockbuster PBMs, which are following the rules, mind you, remember all these have to be reviewed by the government, okay? They would control the majority of formulary management, utilization, pricing, pharmacy networks, and rural mail order services, in the United States. So when we talk about the big three, which we'll talk about in a little bit, that's who's controlling this. It was not until 2017, so we said 1998, 2005, 2007, 2012. In 2017, the US Department of Justice was like, hey, what's going on here? Like they caught on to like something was going on. And they blocked a merger acquisition between Anthem and Cigna. So Anthem and Cigna got blocked. As a result, in 2018, Cigna would go on to purchase Express Scripts and become the first insurance PBM merger, followed by CVS Health, then acquiring Aetna. So we got the full cascade from the beginning of care all the way to the end of care inside of that insurance piece to getting that drug to your patient. As a result, these key players, this is where all of this conversation starts to be had about what's going on with drug pricing and what have you. Now, the actions that were being taken, we could see this all. It was a train wreck inside of our profession. Even when I was a pharmacy student, we were busy on the Hill talking about what was called direct and indirect remuneration fees, or they're also referred to as clawbacks. Those are no longer legal. The clawbacks themselves, like they have to, as of January 1st of this year, they have to tell us what the prices were going to be paid at the time that we actually do the transaction. But before, they could come back, these PBMs could come back later and claw back money that we had already sold to the patient, the drug off to the patient, and claw back on a various amount of very insignificant things, from like days supplied filled to your patient hasn't picked up their script last month, so they are not adherent, and that is your fault as the pharmacist that they did not come back and pick up their prescription, so we're gonna take this, we're gonna charge you on the last time that they filled it. Like, what is going on here? We're trying to provide care here. So with each of these acquisitions and mergers, the PBMs were able to increase these direct and indirect remuneration fees, as well as after-sale price adjustments that resulted in the closure of a lot of independent pharmacies. And we'll talk about why that is important in Kansas specifically. So this is where the term pharmacy desert started coming into play. About 5 years ago, people started talking about this. We were talking about it far before that inside of our profession, but hadn't really given it a name. So in 2020, the US Supreme Court ruled in favor of the state of Arkansas. And you guys may recall this. It was in the middle of all of this drama called COVID, on Rutledge versus the Pharmaceutical Care Association. This allowed for states to regulate the PBMs. We live in one of the most regulated professions ever, and the fact that the people we're doing business with have no regulatory responsibilities is like crazy to me. And so this started the whole entire process of the reviews. So I'm gonna stop there because we're gonna move on with the presentation, but that kind of gives you a little bit of like, what is the timeline? This didn't happen overnight. That's the key piece here. So when I went to school and got my public health degree, I was like, what can I do? I had noticed that we were having a lot of talk about pharmacy. People didn't know what was going on inside of pharmacy, primarily because how many of you guys, by a show of hands, when you go to the doctor's office, pay a $0 copay on your prescription when you pick it up? I pay a $0, maybe $5, right? Like, I'm not thinking that my pharmacist is the one that's paying for my medications, but that is in fact what is taking place at this point in time, is that the program, like in order to provide network adequacy, your pharmacist is usually paying for a portion of your medication, the cost to acquire it, and is not being recuperated at or above cost to be able to stay open. So this made me think, yes, ma'am. Yep, and we'll talk about that. That is not necessarily reality. So this is where we'll talk about that, but like that's where the transparency part with the PBM is needed, because what they say they're paying your plan, we have pharmacists, this is a sidebar, I just moved on to sidebar. We have pharmacists that are, their pharmacy is insured by XYZ PBM, and what they say on their claim, they are filling for those scripts at their pharmacy. What they get on the explanation of benefits as individuals and what they're actually receiving as a pharmacy are grossly different, so our big thing is transparency, transparency, transparency. I'll tell you my flippant comment later in my opinion portions of it, of like what's actually in fact going on. So I felt compelled to do research. I had actually worked with a friend of mine that works for Dispensary of Hope. You guys may or may not have heard of that. It's out of Tennessee. They are a company that works with drug companies to get medications made available for individuals that are 300% below the poverty level, especially in instances where 340B doesn't come into play whatsoever, so that we can get access to medications to the patients that need it. And so she had told me, she's like, we have all these different terms for pharmacy desert, but like, how are you actually going to measure it and how are you going to talk about it? Because everybody looks at it differently. So I'll tell you what my definition is and we'll go from there. So my work in doing this led to a whole bunch of things. And I kind of became slightly the poster child for the Kansas Pharmacists Association to have these talks, and here's why. So these guys are all in contracts with the PBMs, so they can't talk about their contract. Just to be clear, they could face many different things legally by talking about certain aspects of their contract. I am not. And thus, like, I've had people open books and show me so I can speak to it and give examples of what we're seeing. And so this has led, there are a couple of other pharmacists in the state that are just like, I don't care, they can come after me. And they have. Without a doubt, faced some retribution from talking about this specifically, which is why you don't hear a lot of people talking about it, because the very people that are being victimized are then being silenced on the other side. And victimized is a relative term, right? Like their business is, a lot of people refer to it as the mob. Like the money's coming out, nobody knows where the money is, the employer doesn't. Where my role in this is I work with a health system that I help with selecting, and I consult. So I'm a consultant. I am not directly involved with the process, so I can provide feedback of, hey, like that plan, this is gonna be a high cost plan for you. My own health system, just as a quick sidebar story, our pharmacy closed in our rural, I work in a critical access hospital that I manage. Our independent pharmacy, employee health pharmacy, closed in January of 23 they didn't even notify the health system, and it was our employee pharmacy because they just closed immediately. After ending their year in books, they realized that they couldn't continue on. Sold off their prescriptions to the local CVS. That's a whole nother thing. And then closed up shop. So we don't, in our medical plaza, any longer have a pharmacy. And so our patients don't have direct access to medications within our medical health system for outpatient use. To be able to pick up after they've gone to an emergency room. And I say that because in addition to that, there are other players that are also, or other individuals that are, I'll use the word victimized as a portion of this business plan. And that is our providers from prior authorizations. So this is not a single piece. You'll see me on here talking about white bagging, which is just a way, like our pharmacies are not compensated for our services. We're compensated based off the drug, which means that every single time we do what is called a white bag, which is when the company sends us the products or sends them to the white bag is when it's sent to the pharmacy. We prepare all of that and we are not paid for any of it, because we didn't provide the drug, and our upcharge on the drug to provide that care pays for all of the supplies and everything else related to it. So it's a bit impacting health systems as well. So think about your smaller communities like cancer care. Like if I'm not a 340B pharmacy and I'm out in rural Kansas and I'm trying to provide that care, it'll be a negative reimbursement every single time because you won't have enough, you're giving away services when they want you to white bag. Now those of us, like my hospital, never white bagged. We just stood firm. And so we don't. So we're not impacted by that. But a lot of people, when they were told by insurance companies that they had to take their drugs from this specific pharmacy rather than procuring them themselves, it's driven infusion centers and everything else from being able to be viable in rural communities. So that is another side piece of this. The other piece of it is employer plans. I don't know about you, but I'm 41 years old. And I have never paid less for my insurance 1 year after the other year because my prescription drug plan has continuously increased the cost of my plan. So the whole entire piece of PBMs and the business of this and where the transparency comes in is the fact that that was supposed to be decreasing the cost of the plan. So my small hospital that employs about 500-ish employees, last year, our employee plan was $1 million over budget. We planned for it this year. This year, we're another $1 million over budget. So even for our employees in that rural health area, right, we cannot financially be able to provide those medications for our employees. These are people who are paid, have insurance. It's not even like an individual that's uninsured. So it's the whole scope. Okay, so that's the whole picture. So that led to a lot of advocacy. We've been talking with KCUR. We've been in the media because we're trying to raise awareness, because the patient doesn't see this, right? They get the $0 copay. They don't understand that their pharmacist is flipping the other part of their bill. And then all of a sudden there's a closed go to XYZ location. They're like, what happened? Pharmacists don't want to tell their communities, because they're very much embedded in them, how much trouble they're in financially. They will literally, this is like a fatal flaw of pharmacists. Once again, not primarily trained as a pharmacist. I'm a psychologist at primary. Like, they want to be successful. They don't want to have to tell you they're not going to be able to provide care for you anymore. They will literally pay the bill until they can't pay the bill any longer. So a lot of anybody that's in rural environments, like, there are going to be closures. It may be your pharmacy that's up next. I just received notice yesterday of a pharmacy that will be closing at the end of the year, and they literally swore me to secrecy. Like, it's me and the buyer and the people that are a part of the business that know this. Like, because they're like, I don't want to tell my patients yet. I feel like I'm a failure because I couldn't figure out how to make this business model that doesn't work. So, moving on. I know, a lot of doomsday stuff. I do have hope. I will tell you about that. So if you don't pay attention and you're like, I didn't know what a PBM was. Tessa, you told me about the pharmacy benefits manager. They're the people that live between my insurance company and my drugs. This is who those people are. So the FTC got involved, and how many of you guys saw the FTC report or even know anything about it in July that was released? Great. I'm glad you're in the room, because the FTC has sniffed around and did a preliminary report. It's not fully complete, but they made some final sayings in this. And they're like, there is a problem. And we're like, praise the Lord, we've been gaslit for the last 10 years. Like, somebody is finally affirming the fact that there is a problem inside of the way that we actually deliver this care and how it is paid for, and the fact that it's getting more and more expensive when it doesn't need to be. Okay, so here's the big three. So the concern is once again, we said competition is what breeds reductions in prices. This is what's causing there to be a lack of competition. And the reason I say that is if you are in the vertical, so like say I have Aetna, I am forced in my employer plan to do business with CVS Caremark. I can't say, you know what, I don't like how much I'm paying for drugs. I want to have a different pharmacy benefit manager. They say, nope. If you want to keep your Aetna coverage, this is the same across all these. If you want to keep your coverage, you have to use this PBM, and you may be overpaying because of the lack of transparency inside of this and the lack of competition. So I will say this is here is with the KC Blue plans and everything, it's all going through Express Scripts via a contract. So like that is what's impacting some of our local pharmacies more so because of the plans we have in the state. But all of these are affecting everybody and the contracts surrounding these. So let's talk a little bit. We're going to change. We heard about the players. We know the players are out there. It's not an awesome business plan for patients specifically. It's a great business plan for insurance companies. Don't get me wrong. Kudos to them. Wish I would have come up with it myself. Okay, so a lot of times in pharmacy world, we talk about two things. We talk about deserts and we talk about network adequacy. You guys may have heard of network adequacy before or heard it like tossed around, or you may have not ever because this is your first day ever having a conversation with a pharmacist. But network adequacy is very, very different than when we look at pharmacy deserts, okay? So pharmacy deserts and how we define those is defined more off of behavioral related things, meaning like I will only go so far to do something, and when I have to go further than that, I am disincentivized to even participating. So I'll give you an example in a second, but network adequacy is a regulatory requirement. So it's when CMS says we have to have so many pharmacies within so much space, and that is the bare minimum of what we can have to be able to say we have provided an adequate network. Now, inside a pharmacy world, how we create network adequacy is by stating, I will drive the medications to you, and that like gets my network bigger. But ask me, well, I have a pharmacist friend that is here. My independent pharmacist friends might get mad at me for saying this, but I'm going to say that is not the solution to the problem. The reason being is I don't have enough employees to provide medication delivery to every single patient. I don't even have the financial means to provide a driven medication that's delivered to you at your doorstep, because we just reviewed the financial model, right? Like, and I'll show you, we're not making money. So how is that going to happen, and how does that really seam the gap? So this network adequacy and the fact that we are solving it by saying, I have the ability to have delivery services to make it larger and say, I'll deliver it within 30 miles of my pharmacy. Like, it's not real. It's not real. But then that's what CMS hears is, well, we have network adequacy. We do. You saw back on that other slide, we actually talked to CMS, and I was like, it's not about network adequacy. It's about where the patient will go. Like, we cannot deliver every single medication to every single patient. Like, sure, we want to get them out to our elderly patients that can't drive, like, but it's not going to be my 18-year-old patient that doesn't want to get up off the couch to go get their medication. Like, that's just not a feasible thing inside of the model based off of how we're paid. So I look more at pharmacy desert, and this is the health aspect of this, right? Like, what will people actually do? A pharmacy desert shortage area is a pharmacy where greater than 10 miles in a rural area. So like 10 miles is outside of your town. It's the next town over, guys. 2 miles in a suburban area and 1 mile in an urban area. A half a mile in neighborhoods that are low income or have low vehicle ownership. We don't have public transportation, like in some of the Kansas City areas or what have you. We talked about the line. So when we talk about how far is too far to travel, okay, this is where I'm like, y'all get this. I'm not driving to the next town to go get my McDonald's cheeseburger. Like, McDonald's is like, you know what? If I want people to have a McDonald's cheeseburger, I got to put my McDonald's in every town. By the way, we have one in my town. I've never been to it, but I hear that the locals like it. They would not drive to Paola to go get their McDonald's cheeseburger. So what would make me think that to go get my medications, which is a life-saving thing, I'm going to drive to the next town to do that? No go. Same with gas. There's I have like 4 gas stations in my little town. Like, there's competition. Like, they're all healthy. Nobody's going out of business. Like, why is more bad? It's not bad. It's competition, driving down costs, all those sorts of things while providing care. When it doesn't exist, costs increase. Okay, we get all of that. So we're going to talk a little bit about medication access and medication adherence. So this is the gap area here. So access itself is the ability for the patient to get the correct medication for their healthcare needs at a price that they can afford and in adequate quantities. I would say we actually do a pretty good job of access in this country. Like, we have programs like that you can actually engage in, like I was talking about the what did I blank on this? Nashville, the name. Yeah. So we have actual charitable pharmacies that do exist. You just have to network up in it. There's also Mark Cuban's. Mark Cuban is a huge person who is pro transparency in these networks because he understands what we're all going through. Mark Cuban's pharmacy, which will give discounted rates, large GPOs so that we can get discounted dollars on our medications, which is group purchase ordering. The bigger you are, the cheaper the meds. Also, we've got the 340B programs. That's when we're talking about, like, we can get access if we make the right relationships. So if you're struggling to get medications to your patient, reach out to the Kansas Pharmacists Association. Myself or Amanda would be happy to connect you with the people that can get you access to meds, okay? So access in and of itself in pharmacy world is actually, in fact, not an issue. so long as you use the resources, and we can help with navigation of that. Now, adherence is a whole nother ball of wax, okay, right? Like, we have some medical providers in the room. We've all told our patients, like, do X, Y, Z, and they're like, but I feel better, and I'm not gonna take my medication any longer. And they'll tell you that they're taking their medication when they come to see you as a prescriber. I'm gonna tell you as a pharmacist, I get a whole different conversation. It's like, I don't like that medication, I'm not taking that. We've literally, like, there are some pharmacies that have programs where they go back to the provider and tell them when their patient is not adherent, right? Oh man, if our patients knew that we participate in that, they would like not be happy with us at all. But it's part of providing that care cascade. Sometimes it even surprises patients when we say, yeah, we called and talked to your provider about you. They're like, what is going on? I'm like, yeah, this is a regular thing. We just don't necessarily tell you that we're doing it. But they will tell us a lot of things. I have all sorts of examples of working in the emergency department to have like panels being run and being like, hey, I know what the problem is because we talked about they're taking way too much CBD oil and they're cyclic vomiting because of that. Cancel everything. Like, it's crazy what we will hear because we're not the prescriber. It's crazy. But the AMA did a study on what are the top reasons why people don't take medications. And there is a reason why I'm talking about this, just to be clear. I'll get to that, which is fear, cost, misunderstanding, polypharmacy. So polypharmacy means when I'm going to multiple pharmacies, different prescribers, I don't know that so-and-so is filling XYZ. My prescriber also doesn't know that they maybe have duplications. I'm seeing a cardiologist and my GP are both prescribing my heart medications to control my blood pressure. A lack of symptoms. So they're like, I don't have symptoms anymore. Like, what are the symptoms of high blood pressure? Mistrust, worry, and depression. So I ask you, when we talk about how we provide medications to patients, we said we have lots of great access opportunities. And one of the biggest things people are going to talk about is access is mail order. Right? They're like, everybody has a mailbox, right? Well, not everybody. If you are houseless, you do not have a mailbox. However, they're like, well, 85, 90% of America has a PO box or someplace this can be delivered to. Friends, whatever. That's not the answer. We're going to talk about why. But is your mailbox, when I go to my mailbox and I pick up my medications from my mailbox through mail order, how is that going to make me feel better about taking my meds from the perspective of the fear, the misunderstanding that I have of my medication, like my mistrust of being able to take medications? No, I don't think I got any of that solved when I went and picked it out of my mailbox. The other piece is the fact, like, there's regulations regarding how pharmacy needs to make a conscious touch point to provide that education. That's all coming over the phone. Who answers their phones these days? I don't know about you, but I get a lot of election phone calls right now that I am not answering. Same when, my pharmacy maybe calls in the middle of my workday and I don't have time to talk to them right now because I'm not focused on my healthcare at this point in time. So picking that up from my mailbox doesn't help me with medication adherence. It provides access, great access point. Doesn't necessarily help with adherence. Whereas on the other side, this is a real photo, not staged. My friend Christian, she's a real Kansas pharmacist. I'm having that conversation with my patient. My patient's telling me, hey, I see these 3 different providers. One is prescribed this, the other one's prescribed this. I feel really like not okay. Like, other provider doesn't know that they're prescribing these things. We look and we're like, oh, well, that's a side effect of these 2 medications being used together. We need to have a conversation as a whole and figure out which one needs to go. Or, because that's where the mistrust and the fear of taking my medications, because I don't feel good about this. Having that face that's there behind the counter working with your provider group, whatever level they may be, is key to making sure you have the medication adherence portions of this. Access and adherence, not just access, is incredibly important. I've heard when I was in my MPH, we'd talk about pharmacy-related stuff, and they'd be like, we put in a box that gives you the medications at the doctor's office. And I'm like, once again, guys, like, it's not the same. It's access, yes, but it's not adherence. So I encourage you, if you are writing plans that do have to do with outcomes related, if you're doing a public health plan and it's related to getting somebody access to their medications, please include adherence in your plans when you're building your constructs and theories and using those theories to get them to motivated to take their medications, because we actually, in fact, haven't solved anything by just getting a bunch of pills into the world. The reason I say that is time over time over time of working inside of a hospital pharmacy, we have had entire garbage full bags of medications that have been delivered by mail order to the patient. They're old prescriptions, no longer the right dose, what have you, that we've actually disposed of. Think about wow, I've actually had elderly patients take completely the wrong doses of things that they weren't supposed to be taking just based off of, we got great access, we don't have adherence to the right things because we don't have that person to rely on. Now, pharmacists don't charge for our services. That's a fun thing. And so we're not like, hey, you can only come to when you come to my office, I know you filled it out in the portal, you come to my office, we'll have a chat about it. No, the pharmacist, you drop by, you ask me a question, on the side of the football field, I'll be more than willing to answer that question for you and be like, hey, why don't we review those? You can come in later if you want to, or I'll call you back. It's a unique thing to the role of the pharmacist that doesn't really exist due to the payment models that exist in other areas of healthcare. So definitely a helpful part of the cascade. So let's talk real quickly about what happens when there's a pharmacy desert in a medical emergency. So real deal here. So Ciprodex, in case you didn't know, is used for an ear infection, right? You may not know that, but that's what it's used for. So think about this. Amoxicillin, also an antimicrobial or an antibiotic that's used for infection purposes, pneumonia, common cold, well, common-ish cold, non-viral. Epidiolex. This one I think is the most important one. Epidiolex is used for seizures. So when we had the last snowstorm last winter, I ended up with my seizure patients coming inpatient because they had not received their medications via mail order. So we were also utilizing a higher level of care because we didn't have the ability, like their PBM did not allow them to get medications at the local pharmacy, so they were getting them through this. So they weren't ordered. They weren't sitting at the local pharmacy planning to be filled. They ended up showing up. We had to inpatient them and give them medications while they were inpatient to be able to control their seizures because they were very, very concerned about having an epileptic breakthrough because they didn't have them. So this is a picture of Hayes Medical Center. So as a result of not having these pharmacies and having pharmacy deserts, and as that continues to expand, there will be an equivalent use and utilization of emergency centers and small county hospitals, and they can't stand that right now. Like financially, they're not doing well either. So that is kind of the cascade of this downward spiral of effects. Okay, so no more gloom and doom. Yes, ma'am. Yes. 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 Okay, so the question is for the people that are on the recording and are listening, is whether or not the PBM controlling within CMS plans and employer plans, so ERISA plans, if you can pick up at a local pharmacy. And the answer is unequivocally yes. So they have an opt-out program. So they will automatically, a lot of these programs will automatically enroll you into mail order specifically. And they will also charge you a copay if you go to the pharmacy that's local. So they will make it come out of your pocket if you go to a local pharmacy versus getting it from them, which you're already paying for insurance. That's just cray-cray. And they're also in the network. Like, that's what's crazy. That pharmacy is also in the network. And they're like, you're going to pay to go get the meds from the, yeah, it's pretty messed up. It's not looking at the patient. Yes. Yes, because the Medicare plans are managed by those groups. Just to be clear, like United Healthcare will manage a plan, so they're pushing through Optum. And then, like we said, any of the Express Scripts attachments, they'll push it through Express Scripts. Express Scripts is one of the biggest mail order pharmacies in the country. Yes, ma'am. Correct. I don't know that I could speak to the percentage of plans because it is very much contract included. So meaning like your employer may be paying for you to be able to have access to a local pharmacy. Does that make sense? So like in the employer plan, there may be a higher dollar cost if they're electing not to send all of their employees to the mail order side of things. They may be paying a higher premium for you to be able to actually get that local pharmacy fill. Yeah, there's a lot in the Medicare plans, there's gobs of contractual things. Now that's all happening in the contractual language of the plan, both at the state level, obviously, and also at the employer level. So a gatekeeping effect to their costs associated with that. Once again, not good, bad, or ugly, but like when we have emergency events and your pharmacy doesn't exist because they went under and now you have no place to get an antibiotic or what have you. Like in my case, my hospital wants me to open a pharmacy because we don't have a pharmacy any longer that we could partner with, which I don't necessarily want to be in that business because I'm a hospital, I'm focused on acute care. I would rather use my outpatient partners and not make them go away. That's not the goal, right? More access, not less. But those are great questions. So let's talk about Kansas, okay? So in my work with the Kansas Pharmacists Association, we're very, very focused on this. And the reason being is inside of the state of Kansas, we are very unique. As you guys know, we are a tilted state where we have a populace on one side and we have a less populace on the other side, which leads to some very interesting dynamics, unlike some of our fellow Midwestern states, like Missouri, for example, where it's kind of equally distributed along I-70 and then this, resort town. So with that being said, like decision making and what have you at the state level is very much key because what impacts the rural spaces may be caused by the same like exacerbating factor, and what impacts the urban spaces also may be caused by the same factor, but it precipitates in different ways. So the research questions that I included in my study, and this is kind of what I was looking at when I did my study, is what is the current state of pharmacy deserts in Kansas? So we're going to real quick review that. What are the risk factors that are unique that impact patients in rural communities designated as pharmacy deserts? What are the causal factors contributing to the development of pharmacy deserts? And what solutions are being taken to increase medication access in rural areas, okay? So when I said the landscape is unique, we have, if you don't know, we have one school of pharmacy inside of the state of Kansas. It's through the University of Kansas. We have two campuses, one in Wichita and one in Lawrence. So we are only graduating from that university. In case you didn't notice, like most people on the coast are not like, man, I really want to go see the yellow brick road. That's not a thing. So like we're not like a destination station for people who are graduating from other places in the country, right? So our crop of future pharmacists has to be homegrown. Like that is a thing. Now, as a result of this, there was this, even 10 years ago, a very robust existence of independent pharmacies. The state has a huge, robust independent pharmacy. When I say independent pharmacy, this is owned by a single owner or by Joe Schmo, the normal person that's in the community, right? So we have gobs of those. That's the history of Kansas, is it's built on independent pharmacy. So you'll see if you ever interact with the Kansas Pharmacists Association, we are predominantly independent pharmacy driven because that is what our pharmacies exist as, okay? So we said, mom and pop, though, when they have one location and ain't doing good, like they can't stay as one location, right? We have to have group purchase ordering. We got to reduce costs. We got to have competition. So we do that by conglomerating. So remember what I told you about PBMs? The conglomeration factor is what is essentially brought us here. So something similar has been going on inside of Kansas. So inside of Kansas, it used to be me, I'm Tessa, I own my pharmacy, this is my pharmacy. This is my only location, I own it. It's diverse, okay? So we have 104 out of 105 counties in Kansas that have pharmacies. Before, you would maybe own 2 or 3, not 15, not 20 pharmacies. So I want you to think about lessons we learned in the past. Where we're at now is you won't see as many closures of pharmacies when I show you that. And the reason being is we got a couple key players that have been purchasing up and creating conglomerates. Now, they would be mad at me for saying this, but I'm going to say it anyway. That is not the way. As soon as that one company goes down, 15 counties went down. So that is currently what's taking place. We have 3 big, and I will name them for you so that you know what they are, because they'll be in your communities. Auburn is a huge regional conglomerate, and not bad. I mean, it's not a bad thing. They are doing this to save things. But if financials go bad, like that's a lot of pharmacies, okay? We have MidCan, which is my friend. Her name is Sloan. She's the president of the Kansas Pharmacists Association. She's a part of this. It's not a bad thing. Once again, they are trying to save these pharmacies. I mean, they have a pharmacy all the way down in Oklahoma that they can't get a pharmacist to come to. So they haven't even been able, they purchased it and they can't even reopen it because they can't get somebody out there. So they have a huge, in the middle, a huge amount of those pharmacies that are independent are theirs. And the third is Osborne. Osborne has a lot of different individuals that are investors in it. But that is a lot of our, Osborne has investments in a lot of the independent pharmacies in the state. So not bad. This is how we're surviving. But what I'm telling you is, if Hy-Vee goes out of business and decides we ain't doing pharmacy no more, if Dillon's decides they're going out of business, we're not doing pharmacy no more, that all goes to our independents. They can't handle the influx. Just to be clear, that is financial disaster. What happens? What happens? How do we re-strengthen this? Okay. That's the reality of the Kansas landscape, which is very, very unique. Amanda will tell you that. Very unique compared to across the country. But as we're conglomerating, we create a future problem. So this is, according to Telefarm, who is using the same data that I'm using to determine what a pharmacy desert is. These are all the towns in Kansas that are considered pharmacy deserts, meaning, especially in the rural spaces, that's 10 miles to a pharmacy. We are one of the most extreme states for pharmacy deserts, just to be clear. In addition, part of my study was to overlay the health shortage areas for physicians and providers, right, on top of this. Because remember, the pharmacy stays in town when the local provider starts providing care for 3 towns. They're no longer in town every day. They're now in town Monday, Wednesday, and Friday, and they're in this other town Tuesday and Thursday. Like, the pharmacist is still there. Now imagine now that provider only comes to that town, because we have provider shortages, right? They only come to the town 1 day a week. So when I need to have a conversation, remember, I don't have to charge to go talk to my pharmacist. I show up and I talk to my pharmacist. My pharmacist helps me out. They get me some OTC care. They refer me if they need to refer me back to that provider to get me care. What if that town no longer has a pharmacy? Now we only have care for that town 1 day a week that's currently accessible. This creates a whole nother problem. So the idea was to take that and the governor medically served areas, designated medically underserved areas, and say, where does this overlap and what areas are actually at greatest risk and how much of that overlapping occurs? And that's where the results are. These results are in words because I'm currently working on getting my map taken care of. So you guys will be the first ones to see my map. So as of February 2024, which is when these will be updated things when I go to publish, 210 towns in Kansas that met there were 210 towns in Kansas that met the criteria of a rural pharmacy desert. I did exclude in my study any of the urban spaces. That was part of an exclusion criteria. The furthest distance from a town to the nearest pharmacy was in Mattville, Kansas. It was 25 miles to their local pharmacy. The average number of miles between a town classified as a pharmacy desert and the pharmacy was 13.3 miles, okay? Of the 63 at that time, this changes annually, governor designated medically underserved areas, 73% contained at least one pharmacy desert, okay? So same areas, same problems, same. Approximately 58% of the pharmacy deserts in Kansas are located in a medically underserved area. And then 83% of pharmacy deserts in Kansas are also located in an HPSA area. So it's not good. Like, we don't want this to all, like, we don't want the pharmacy portions of things to collapse. And then that introduces yet another disparity inside of our state. So what's going on right now? So our friend who came out of nowhere, Benjamin Jolly, so when you get the slides, you can use this link. This is updated all the time. Made a map of the entire country. I zoomed in, got you guys the data for Kansas. But over 2,300 pharmacies have closed across the United States this year alone. This is crazy. Like, You didn't know about it before you came in here, but a real problem. It is a real problem. So on this map, to orientate you to it, chain closures, that's your CVS, Walgreens, biggies, okay? They're primarily in the Kansas City area. If you were in the Kansas City area, you may have noticed you went to your local CVS and they don't exist any longer. Like, that's a real thing. And some of those were the 24-hour locations, just to be clear, so that also cut off an area of care. Closures, just regular old mom and pop shops, are these yellows that exist on here, okay? And then ownership transfers. This is where our friends, the three local independent groups, conglomerates, this is where they're saving the world. Like, they're trying to stop it. They're trying to like stop gap this. These are things that have transferred to independents or transferred also where the local pharmacy is staying open. Like, it's staying open, it may be under new management. Not a complete closure of the location. That's the definition. Now, to be clear, when a pharmacy closes, just in case you don't know, I got 10 minutes and I gotta be fast. When a local pharmacy closes, they have to they are required by law and regulation to transfer their files to another pharmacy. Who do you think receives that? Do you? Yes, the chain pharmacies receive that. Why is that a problem? They are. How do you think we got here? Yeah. So who's closing right now? You guys hear the news lately? No, because you're not paying attention to Pharmacy World. So CVS just changed their CEO in the last week to the manager of the PBM. He is in charge of it now. So if I was writing the book on how to run business, now once again, great business. I think this is great if I'm standing on their side, right? I purchase everything I can purchase, right? I say, I put you out of business. I'm sure Amanda's gotten to hear this. She's like, oh my gosh, this is diabolical. I purchase everything I can purchase. I put you out of business. I get all your scripts, all right? I buy them while you're down. Pennies on the dollar, okay? I pull them in. You know what? It costs me a lot of money to run a brick and mortar pharmacy. So you know what? I'm gonna shut that down. How am I going to deliver those meds to you? I'm not selling my scripts to somebody else. Nope. I'm sending you through the mail order. So now we have a disproportionate amount of mail order. You can't compete against the mail order. It's the lowest cost to be able to actually run a pharmacy. It's all centralized, right? So that's how we ended up here. And that's how the urban is being driven into the ground, is through that part of the model, just to be clear. So causal factors, we already talked about a lot of that, but this is a great, it's kind of small, so this is a great example. This is a pharmacy that's in Georgia that when they closed, they took a no crap given approach and decided that they were gonna post it, knowing that they were gonna get in trouble for it. So this shows atorvastatin, some Lipitor. You guys know the med? Okay, take it for blood pressure. If they were selling average payment to the 3 closest retail chains, large stores, $46.87 per prescription. The payment to this independent pharmacy was $1.90. It is the difference of 2,367%. That's what's happening in the background, and it's not unique to this in any way whatsoever. So this is what's going on with your pharmacist. This is why they're like, oh my gosh. And they are very, very much traumatized by this in the independent sector. I can step away from it and be like, this is business, and they're trying to do their business, but it's impacting our patients, and that's not okay. So that's the reality. This is my quote. I love this quote. We often preoccupy ourselves with the symptoms, whereas if we went to the root cause of the problems, we would all be able to overcome our problems for all. So one big thing that Kansas is doing, and this is part of the proposed solutions, and surprise, this is my last slide, guys, is we are fighting for transparency. So if you are part, so we talked earlier about cooperation versus collaboration. And one big thing that the Kansas Pharmacists Association, and part of the reason why I'm here, and Amanda and I've been presenting different things at different external to pharmacy groups, because we have been insular and we haven't told you guys what's going on, but it's going to impact you as well, and the patients that you serve in providing that care. It's going to impact your own personal health, just to be clear. So the more people that actually know what's going on and are educated on that will be able to see it coming in their community to plan against it, right? So the biggest thing here is we at the Kansas Pharmacists Association are going to be running a very large bill And I'm not asking for your support, but if your organization that you're a part of wants to collaborate and support that, we would by all means take that support. We do have a huge amount of support to move forward with this, and it's really built on transparency to make sure that we do not have all these pharmacies collapse. The reason being that I say that is I think we're already beyond the inflection point. I think it happened in January of 2024. To be honest, if you're asking me as a businesswoman, like, I don't know how their businesses, they aren't being like fully transparent. The pharmacists and pharmacy staff and owners themselves are not being fully transparent on this. So I know it's bad when they don't want to talk about it, right? And so January 2024 was when the end of the DIR fees came. So they got a bill in December of 23 from the drug companies of what they were clawing back. And then they immediately got those fees front loaded onto their January prescriptions. So the cost, like what they were receiving in January, so they had to pay a big bill and they received less on the front end of their payments in January, and cash on hand wasn't there. So that is what kicked off all of this across the country. Now we needed to change it, like it had to change, right? But that double whammy that came across there made the inflection point of all these closures happen. They didn't have the cash on hand, they were already squeezed anyway. So what do? We got to stabilize the market. We are the most regulated. I'm supposed to stay away from that. We are the most regulated profession that exists. Okay, like the EPA is less regulated than pharmacy, just to be clear. It's funny because I could tell you about pharmaceutical waste and you'd be like, yeah, they are way like less regulated than y'all. We have to fix the problem at the state level here. Like the federal level is going to continue their FTC stuff. They're going to have conversations. As you guys know, money makes the world go round. So all those things, but we have to have some sort of intervention here at the state. We've had one PBM reform that took place, how many years ago, Amanda? 4, 5? 5 or 6 years ago, that allowed the insurance office to make them register so they could be, but there's no teeth in it. And that's part of that. So we will be making one last ditch swing effort. If we fail, I'm just going to tell you that we will see closures and they will be massive. So any support, that's where we're starting because this has to happen. Other things is utilizing innovative solutions in areas where pharmacy deserts already exist. And so we haven't necessarily done a lot on this, but telepharmacy is also an option. It's a better option in my mind. Our independent pharmacists hate this, by the way, because you can have a location that's a smaller location that's remotely held by a primary location. That is what will have to happen as a solution to what is to come. They won't like it. I don't love it, but it does support the chain, which is really kind of like a satellite pharmacy, is what it is. Other things that we've seen is mobile pharmacies. We do have the ability to have a mobile pharmacy in Kansas. This does still require pharmacist involvement, right? So we're still getting the adherence and the access and involvement from that perspective. Other really cool things that are completely not associated with this is we have Cardinal Pharmacy, which was out in, what's the name, Hoisington. So Cardinal Pharmacy in Hoisington, if you know anything about or you're from that part of the state, there was a tornado that went through, the pharmacy got knocked over, gonzies. It took them 9 years, but the community got involved and was like, we need to raise a pharmacy because it's important that we have care here locally. So I do see a lot of community involvement in the future to be able to re-raise these into communities that are considered deserts. It's going to be completely innovative and never seen yet. I don't even have, honestly, until this really hits the fuel to the fire, we're going to see all these innovative ideas on how to maintain access and adherence at the same time. And then one key thing is stabilizing the workforce. So how many of you heard about the walkouts, CVS walkouts in the city, and you were like, what is going on there? I will say I am very proud. Amanda was in on this with me. So I used to work, so the corporation that I used to work for when I was in human resources was Target. And this was my people that were walking out, my previous people. The key location was a location that I used to manage as a human resource officer. And so really cool from the aspect of being able to be involved with that. That event in Kansas City actually turned the whole entire narrative on its head. So, but prior to that event, we got out ahead of it, and we're one of the first associations to make a stand on this is a public health related issue. This is not a pharmacist shortage issue. This is the fact that we don't have pharmacists in places where they should be because we're putting profits over patients. And that changed the entire narrative from a national standpoint. We got a lot of associations to go back in and make comments about this, that we couldn't at the national level from the corporation side be like, this is a pharmacist shortage, we can't get pharmacists. No, that is not the issue. The issue is the fact that we can't get pharmacists that are willing to be subjected to being in unsafe conditions where they can make an error, lose their license, and lose their livelihood. That's not okay. So that's the core root issue. Now, the core root issue in the independent pharmacies and such, and why we have the shortage areas, you guys saw the map that they proposed earlier, and I got 1 minute, is because we have individuals that are coming through pharmacy school and they see those pharmacists struggling. They're doing rotations out there with them and they're like, they can't financially make it. I don't want to own a pharmacy. So there's been this whole entire drive toward other areas of pharmacy, and rural health is not their priority because they're seeing everybody struggle. So it's all interrelated, like we said. So we have to fix the root cause. And we're hoping, like I said, pleading, whatever, that putting that big inflection point of the transparency piece so we can all understand what we're dealing with and where the dollars are actually going and redisperse those appropriately would actually at least give us some CPR to be able to readjust. Our graduates need it here locally. People interested in pharmacy as a viable career is definitely down. Now, do we have a shortage right now? No, we just have a shortage of people willing to go into situations that are not longitudinally viable. But we will in 10 years, for sure, as people retire out of the workforce and what have you, so that needs to be corrected. But I do have hope, and this is why. Because the business side of me knows, not the pharmacist side. The pharmacist side is all gloom and doom. But the business side of me knows that rebirth happens in the middle of disruption. And we're in the middle of a disruption time period, which means that things that we've never seen before will exist because somebody will be creative in how we're going to deliver access and adherence to our patients. And it might very well be one of you guys that brings up something as an external perspective that we're able to figure out how to solve something in a way that we've never solved it before. So I want to thank you. I'm more than willing to take your questions, but I also know that I talked a lot. I want to thank you guys for giving me the opportunity to at least educate you on this. I appreciate if you have any questions for me or you have somebody that you want me to talk to. Amanda and I and the Kansas Pharmacists Association are more than willing to engage in those conversations. But I hope that you learned at least one thing about not just for your own care, but for the people that you take care of. So thank you guys. Oh, yes. They told me that this was a very important piece of this. Okay, so first, there is a survey for the QR code for this presentation is right here. So if you're gonna snap it, do the things, because you gotta do the things.
And if you're not able to do that, see me and I can pull it up for you from my device. But if you have questions, now's your time to...
And then I'm all supposed to tell you that box lunches are gonna be available earlier in room 130. I will say when you look at my slides, there are tons of references in here, just to be clear. Everything that I've used to produce any of my studies are all inside of here, and you can go to those as well. But you had a question, sir.
Yeah, this has really been great. My head is spinning.
I'm sorry. We have medication for that. Yes, of course.
Thank you so much for this. A lot of the CVS and Walgreens pharmacies, anyway, now have minute clinics or something like that in there too. Is that making any difference in the fundamental economics of healthcare or of pharmacy specifically?
Those organizations have actually recently, their board of trustees and what have you, have kind of pivoted away from that. I know Walmart recently, Walmart was all in. They were like, we are all in, we are building this out. They were like, it's not profitable. They're facing the same things, if you work in a health system or you work in private care, all that, they're realizing the insurance company, the payment model's not there. And so they're turning away. Same with minute clinics inside minute clinics and healthcare hubs, I think it is for CVS. They're turning away from it too, realizing, because remember, those locations, although they're part of a same vertical thing, they also are realizing that they're not being paid, which is why they don't have as many pharmacists in their pharmacy, because that sector is being squeezed to pay the other sector, essentially, from the business portion of the model. So the shareholders, specifically for CVS, are like recently, within like the last 2 weeks, are like, we will focus on being the healthcare organization that we're supposed to be, not getting involved with all this other stuff. So cliffhanger, watch CVS. Crazy things are about ready to happen. Because they are like, we will make sure that the CVS brand exists. So their shareholders, which is just that part of the company, right? Like not the whole conglomerate, are like, nope, we're not doing this anymore. We're not going to be the ship that goes down. So it'll be interesting to see what happens. But they're realizing that those models are not profitable either. So they're kind of sucking out. They went in, it was a big expansion, and now they're like, back in. Walgreens also just announced that they are closing 1,200 more locations than the third that they already announced across the country. So that will affect a lot of smaller. I know in my town that I work in, I don't live there. They literally sit across the street. CVS is on one corner, Walgreens is on the other. They're not making money, so somebody's going to close. It's just which one will close first. But that's a great question. Any follow up to that? No. Okay.
No other questions?
I have lots of friends that work in the Dollar General world that used to work for Target Corp. That's an interesting conundrum. So a lot of the executive leadership is past Target Corp leadership, and I would say that they have most definitely looked at it, like given it an eyeball. But because a lot of us lived in Target Corp world and know about why we sold the pharmacies, which cliffhanger was because they weren't profitable and they could see what was going to happen. So the only reason your Dillon's, your Hy-Vee, whatever, has a pharmacy is not because the pharmacy itself is profitable, it's because it brings in patients. So I could see Dollar General, if I see Dollar General getting into the game, it would be one of those opportunity buys where there's no longer a pharmacy in town, so they can pull people through to shop there versus shopping at the local grocer that doesn't have a pharmacy. We studied when I was in Target that the basket, the increase was like 3 times of what they put in from around the store was 3 times in the basket of a pharmacy consumer, because you go to the pharmacy, they say you gotta wait for your meds, and you walk around and you're like, ooh, this looks good, and you stick it in your basket. That is what was occurring. So there is market data on that, but I don't think that they will jump in the small towns until the local pharmacies don't exist. They want zero competition so that they can put those other things in the basket that they're making higher margins on. You can always join us at the Kansas Pharmacists Association meeting. We will be in Lawrence, Kansas next August. My people have also asked for this as a webinar because we haven't even talked about the data. They were like, you should do a webinar on this. I was like, don't you already know it? You live it. But there's a whole, like a different perspective from being on the outside to being on the ropes right now of like, how do you look at this objectively and understand it for what it is?
Yeah, so articles want to appear, and I know the media, does what the media does. Crime is why we're closing these pharmacies.
Crime is up. It's killing a lot of those or any of those companies. So fun facts, my husband's a big manager inside a Target world, and they have the same problem, sans a pharmacy, of having to put like all that stuff behind glass and then watching the sales go down and then being like, well, you have to accept it. So you're right. They also figured out that what should I say, middle class white mothers, they've closed down a lot of the self-checkouts because they would like not check out all their stuff. So like they close them down during certain times of day when it's like a high crush of certain target populations that they're seeing walk out with merchandise. So I think that's very much a societal driven problem that's somewhat separate from this, but also is like gonna fuel it, right? Like a different business piece on that, but that is not uncommon. A lot of the independents Kansas City, okay? There used to be several independent pharmacies in that space that closed down just for that reason alone, from like being held up for their meds, like not fun, to like not like the insurance for the facility costs so much when you are a victim in that way. So that is yet another factor, not necessarily coming from the same precipitous, but definitely a factor that is coming into play. And yes, they are talking about that because in some of the, primarily like urban core, that is driving some of those food deserts and pharmacy deserts as well. But it's not just an urban core problem. I think it's just where they're closing is somewhat opportunistic.